بسم الله الرحمن الرحيم. اللهم صل وسلم وبارك على نبينا محمد. اللهم لك الحمد. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. Welcome back again to our continued sessions on pathophysiology of congenital heart disease. In the last few sessions we've covered pathophysiology of cyanotic congenital heart disease. Today we'll cover the pathophysiology of acyanotic heart disease, namely pathophysiology of left to right shunt, and we will be left inshallah with pathophysiology of obstructive cardiac lesions for the sessions to come. So what is a left to right shunt? A left to right shunt is, from the cardiac point of view, is blood coming from a systemic circulation to the venous or pulmonary circulation. That's what we call a left to right shunt. So the left means the systemic, the left heart, and the right heart. And the right heart is represented by the venous return, the right atrium, the right ventricle, and the left side or the left heart is represented by the left ventricle, the left atrium, and the aorta with all its branches down to the body. The most common typical examples of lesions in the heart and outside are three. First of all, the ventricular septal defect. Second is the patent ductus arteriosus, and one of the most common is the ASD. I left the ASD to the end intentionally because I want to do the high pressure systemic left to right and then do the low pressure because of some significant differences between both. So what is a ventricular septal defect? Let's go before that and see the normal heart and refresh our minds and selves. This is a normal heart. You can see here, this is the inferior vena cava. This is the superior vena cava. They receive the blood, the venous return, from the body lower down and from the body upper, which is the head and neck and the arms and the upper chest, and the IVC receives the body, the abdomen, the legs, and everything below that. This blood comes to the right atrium, to the right ventricle, to the pulmonary artery, to the lungs, back to the pulmonary veins, to the left atrium, to the left ventricle through the mitral valve, and up the aorta to be ejected to the body. So this is the normal flow of our body. When we say left to right shunt, that means there is blood either from here or from the aorta that can go to the right side. So how can we figure out that? That's not difficult actually, and I'm going to use the drawing to just give the possibilities. So the possibility of a left to right shunt from the left ventricle has to be through the interventricular septum most of the time. So what is the interventricular septum? It's the muscular barrier or border or wall between the two ventricles. And if we have a defect there, what we call a ventricular septal defect, I'm just going to wipe out part of this. And now we have what we call a VSD, or a hole in the interventricular septum. I drew it here in the middle just for simplicity, although VSDs can be way up below the great arteries or way down in the apex in different many areas or around the AV valves. So we all know that the left side pressure and left side resistance is about 4 to 5 times the right side pressure and the right side resistance or more. To imagine if your left ventricle going to eject, that means contracts, the blood, if there is a VSD there, a ventricular septal defect, will have the choice to go up the aorta. Sorry for the color. I have to do it slow. Or go through the VSD to the right side. What would determine the blood going this way or that way is obviously the pressure and the resistance. And we all know that the right ventricular normal pressure is low, less than 25 millimeter mercury, while the left ventricular pressure, systolic pressure, is almost averaging an 80 to 120 millimeter mercury. So pressure-wise, the blood will like to go more through the VSD to the right side. This is number one. Number two, the pulmonary vascular resistance, which is around 1 or 2 Wood's unit, compared to multiples of that on the systemic circulation, would also give an advantage to the blood again to go through the VSD to the pulmonary artery. This does not mean that no blood will go to the aorta, but this means only there is more blood going. So if we now talk about that, we know that the right side, right atrium, right ventricle, is receiving the full cardiac output from the IVC and from the SVC. Obviously, if it is receiving the full cardiac output, any extra cardiac output will be an addition. All of this is going through here, which is represented by this arrow. Now, we have another arrow going through the VSD to the right ventricle. So how many arrows will be there in the pulmonary artery? We will have 2. You see? And only 1 here. This, if we translate it into more scientific language, the pulmonary artery will see more cardiac output than the aorta. In this condition, 2 to 1. A 2 to 1 shunt, or double the cardiac output to the left, to the right side, and 1 of the cardiac output to the left side. This does not mean that the left side will not get the appropriate cardiac output. This only means that the right side will get more cardiac output. The left side will still be maintained, except in conditions which are extremely rare, where the cardiac output is totally, almost all going to the pulmonary arteries, and the patient at that stage will be in severe heart failure and low cardiac output stage, which is not the usual in VSDs or PDAs or ASDs, left to right shunt pathophysiology, and we're not here to talk about the unusual. So a ventricular septal defect, which is a hole or a defect in the interventricular septum, be it whatever part of that interventricular septum, will allow the blood to shunt from the left to the right. This is the main principle. So the second principle here, this left to right shunt, it's coming from oxygenated blood. I should have drawn actually with red. I'm going to put it on now with red. It's oxygenated blood from the left side to the right side, which is deoxygenated blood. What this translates on the patient is that the patient will not be cyanotic, unlike what we talked about in the pathophysiology of cyanotic congenital heart disease, where it is a right to left shunt and then the patient will look blue. So these patients, clinically, they will look pink like anyone else, because actually they could be even pinker, if quote unquote we can say, but obviously that's not true. The only way we know is we calculate the shunt and calculate the O2 content, and then we know how much oxygen they have on the right side or on the left side, but that's beyond the talk today. So they will have no sign of cyanosis. So what would they have? This is now extra blood going to the pulmonary arteries. I'll take you step by step so you can actually guess or know the pathophysiology by yourself. If there is more blood going to the right side, let's start from the right ventricle. Pathophysiologically, what would happen to the right ventricle in case of a VSD? One would say, well, it's receiving extra blood, so the right ventricle should dilate or get hypertrophied. This is actually not true except in huge, large VSDs, which is again not the common, but I will talk about that at the end of this presentation. So why is that not true? The RV will not dilate and will not hypertrophy in usual small to moderate to large VSDs is because the right ventricle will receive the blood during systole or diastole. The right ventricle is going to receive the blood in systole, so it will be closed. Basically, the blood is not going into the RV cavity, or the RV cavity is not receiving. The RV cavity is actually bypassing or just becoming a route to push the blood actually to the pulmonary artery. And the receiving end in systole will be truly this arrow, because if we say right ventricle will be contracted, just to draw it, it will be like that, contracted. It's not going to dilate or receive any blood. The blood is just going to be shot up to the pulmonary artery. So the receiving end in systole is actually the pulmonary artery. So pathophysiology number one, the right ventricle will not hypertrophy and will not dilate. The pulmonary artery and the branch pulmonary arteries may dilate and may become larger if the VSD was large enough to transmit the systemic pressure to the right side. And I'll talk about that in a second. So the right ventricle is not affected. Would the tricuspid valve be affected with all of this? Yes, it would. In the extreme cases of very large VSDs, if it causes pulmonary hypertension, the right ventricle, the right AV valve, the tricuspid valve, may have tricuspid regurgitation, may leak, okay? And actually, some VSDs that open close to the tricuspid valve may deform or shoot their shunt through the tricuspid valve and cause what we would call a semi or a fake tricuspid regurg, when the valve is truly not regurgitant, but the jet of the VSD is being shot, and this is what we call the Garbudi defect. Beyond the too much sophistication of this talk. So the blood now gone from the VSD in systole through the RV. I didn't say in the RV, I said through the RV. It's just using the RV to the pulmonary arteries. Now where is it going to go? It will go to the branch pulmonary arteries, to both lungs. And what will that cause? Because we know that these branch pulmonary arteries are also receiving the normal cardiac output, the blue. So if they receive the normal cardiac output, that means each one of them is seeing now more flow, more blood. We call that a state of increased pulmonary blood flow. A state of increased pulmonary blood flow. We're not talking here about pulmonary edema. I'll come to that. We're talking about a state of increased pulmonary blood flow, and that's why in patients with significant left to right shunt through a VSD, on an X-ray, you will see the increased pulmonary vascular marking. Now these vessels, the pulmonary vessels, have more blood in them. They will show more easy on the X-ray. In a normal X-ray, we see very little of blood vessels in the upper part of the lungs, in the apices of the lungs, and we see a little bit more on the lower part because blood is actually going lower because of gravity effect. Except in left to right shunt, especially a VSD, we will see actually what we call redistribution of pulmonary vascular pattern or increased pulmonary vascular appearance. That's an indication of too much blood into these PAs. So on an X-ray, that's how it shows. Where would this blood go back to? Obviously, the normal cardiac output is coming to the pulmonary vein, now we have the additional cardiac output coming to the pulmonary veins also. So the end result is, and this is the most important part, the end result is that the left atrium is going to see what? Much more blood than anywhere else, because it's going to receive the blood in systole or diastole. Obviously, it's receiving it in diastole. So left atrium now has the blue, the usual cardiac output from the right side, being oxygenated, coming in oxygenated, never mind the blue color, and the red, which is the additional already oxygenated blood coming to the pulmonary veins. If you are not contracted, if this atrium is not contracted, and we know atria, even their contraction is not like ventricles, they still have a lot of space. So having this too much blood, the double cardiac output, or plus or minus, or quadruple, or triple, or 1.5 or 1.8, whatever, it's increased pulmonary blood flow will lead to increased left atrium reception of blood or cardiac output in the left atrium. And the rule says, if a chamber receives the extra blood flow in diastole, the chamber will dilate, because in systole, it will not allow that volume to dilate it. In diastole, it's already relaxed, so immediately left atrium will dilate. Let's walk with the blood. Now left atrium receives that extra blood. It will eject it into, or through the mitral, into the left ventricle. The left ventricle will receive the blood in which state? Again, it will receive it in diastole. So it's relaxed. It will receive all that volume. And here we are talking about healthy myocardium that has excellent elasticity and has the ability to dilate and receive the extra volume. So here is the other pathophysiological effect that we see with left to right shunt through a VSD, which is left atrium and left ventricle dilatation, normal response. Some people talk about being abnormally dilated or so. No, this is a normal response of cardiac chambers to increase volume, because they have muscles which are quite elastic and have a normal Laplace law, and they just dilate enough and then contract even stronger because of that stretch effect that has happened to them because of the extra volume. So left atrium and left ventricle dilatation is a feature of this disease, while right atrium and right ventricle is not, mainly because VSD flow is mainly received by the pulmonary arteries, the left atrium and the left ventricle, both left atrium and left ventricle during diastole, so they will dilate, and the pulmonary artery during systole. When would the pulmonary artery dilate? If, and this is the second effect of a left to right shunt from a VSD, which is if this VSD was large enough to transmit totally the pressure from the left ventricle to the right ventricle, then actually it acts like an equalizer. It equalizes the left side, the right side pressure. And hence, if this has happened, we will have pulmonary hypertension. Pulmonary artery pressure will be almost equal to the aortic pressure, because again, in systole, they are being equalized through a large VSD. There is no resistance, no restriction of pressure nor volume in large VSDs with no previous fixed pulmonary vascular disease. In a normal heart, if the VSD, in a normal heart and lung, if the VSD is large enough, it will transmit a large volume and will equalize the pressure between the left and the right side. Hence, we will have pulmonary hypertension. If it goes for a longer time, the PAs, the pulmonary arteries, will have to dilate to accommodate not just the volume, but the pressure also. And the secondary effect will be on the left ventricle, because the left ventricle will see high pulmonary artery pressure all the time. Then the left ventricle, the right ventricle, I said the left is wrong. Let me say it again. With a large VSD, the pressure is equalized. We will have pulmonary hypertension. The right ventricle will see high pulmonary artery pressure, and hence the right ventricle then will start to hypertrophy. And if you leave it for a too long time, it actually may dilate. And then we will get the number 4 effect, which is biventricular hypertrophy, that we can see in large VSDs. So what would that do? So be it. I mean, this is blood going in. This is PA pressure being, this is systemic pressure being transmitted to branch pulmonary arteries. So what's in it? What's there? Now we'll go to, I think, point number 5 in left to right shunt from a VSD. The lungs will be flooded with fluid. If it is a small VSD, that amount of blood or fluid is actually minimal. It will not do anything to our lungs. If it is a moderate VSD, the amount will be moderate. It may affect the lung function only during situations of increased metabolic needs. That means during a significant exercise. If it is a large VSD with too much cardiac output going to the lungs, then the lungs will not be able to perform or do their functions, even at rest, because of what we can call now, we previously called it increased pulmonary blood flow. We can now call it pulmonary arteriolar edema. Pulmonary arteriolar edema, compared to what we know from congestive heart failure, pulmonary venous edema. In congestive heart failure, when we have poor left ventricular function for many causes, myocarditis, ischemic heart disease, cardiomyopathy, be it, the left ventricle end-diastolic pressure goes high, the left atrium pressure goes high, the pulmonary venous pressure in the pulmonary veins goes high, and hence the normal pores in the basement membrane in these vein and venules will actually become wider, and here we start leaking the serum into the pulmonary interstitial tissue area outside the alveoli, and we have pulmonary interstitial or pulmonary venous edema. That's what we see in congestive heart failure for causes other than left to right shunt, or in the extreme cause or time of a left to right shunt with biventricular failure. So going back, with a large VSD, with pressure being high in the pulmonary arteries, we can have pulmonary hypertension, right ventricular hypertrophy, biventricular hypertrophy. With large shunts, we can have pulmonary arteriolar edema, and the symptomatology then is reflected by dyspnea, whether it is dyspnea at rest and tachypnea, or with moderate exercise, or with severe exercise. In most of these times, the patient will still remain pink and not get cyanosed unless the pulmonary edema is quite severe. I'll finish the talk about VSD left to right shunt by saying, if we have small VSDs, which we mean, what do we mean by a small VSD? Something less than 6 millimeter in diameter, or less than the aortic valve annulus, or less than the diameter of the left ventricular outflow tract. If it is less, then most of the time This VSD will not shunt blood enough to cause too much cardiac output going. Most of the cardiac output will actually be less than 2 to 1, maybe 1.8, maybe 1.5. And it will be extremely restrictive to pressure, so it will not cause pulmonary hypertension. This is in the pathophysiology of a tiny or a small VSD. Moderate VSDs, they will be almost always restrictive to pressure, so they are very unlikely to cause any pulmonary hypertension, but they can push enough blood to cause symptomatology and may need treatment for that. Large VSDs obviously will shunt a huge amount of blood, and pulmonary pressure will also be elevated. One or two last points about left to right shunt in a VSD. Large VSDs, when they transmit pressure and volume, if left untreated, the pulmonary pressure can become fixed, or the elevated pulmonary pressure can become fixed, or we can call it reversible or irreversible pulmonary hypertension. In most cases, it is reversible pulmonary hypertension. Once we close the VSD, the PA pressure will just drop to normal. If we leave that VSD for a long time doesn't mean years, by the way, in large VSDs. It can be anything between 9 to 12 months. That's why we close large VSDs much earlier, around 3 to 4 months, maybe 6 months maximum. But larger VSDs, if left to age around 9 months or even 12 months, they can cause irreversible pulmonary hypertension. There are many cases that don't develop that except after a few years, but here we're talking about how we can protect patients by understanding pathophysiology. And in a VSD which is large, which is transmitting a lot of cardiac output, extra cardiac output, left to right shunt to the pulmonary arteries and pressure, we do not allow it to stay more than 9 months in a patient, in a baby, because it can cause irreversible pulmonary hypertension. What is that? That is the pulmonary arterioles, media muscles will start to hypertrophy, and then this hypertrophy become non-reversible, and then we start seeing intimal pulmonary arteriolar injury, and on top of that injury, thrombi forming, and on top of those thrombi, fibrosis, and we end up with fixed pulmonary vascular bed injury or contraction that does not dilate, because now there is anatomical and pathological changes on those that can be irreversibly unchanged. Obviously, a VSD can do that if left for a long time, and a shunt from a VSD can actually reverse into a right to left shunt. If the VSD, the large VSD, is not treated for a long time, and then the patient develops pulmonary vascular fixed disease, that will actually make the vascular resistance in the lungs higher than the vascular resistance in the body. And we said before that the shunt depends on the pressure and the resistance, and once this pressure is higher and the resistance is higher, so when we develop, or when the patient develops fixed severe pulmonary hypertension, now the resistance and the pressure are higher on the right side than on the left side. So let's walk now with the cardiac output. On the left side, the left atrial flow will go through the mitral down to LV. Now it has the choice either to go to the VSD or up to the aorta. Obviously, if the resistance and the pressure on the right side is higher, it will actually favor going to the aorta and not much going through the VSD. But this is not the end of it, but actually it points to an important part, that pulmonary hypertension initially shows no symptomatology, and the patient looks like he's getting better. And that's a very deceptive point, because now the left to right shunt is much less, and the patient doesn't have pulmonary arterial edema, will breathe very nicely and very good. But that's not a good sign with large VSDs, because it means immediately that we are developing severe pressure. What will happen on the right side, the SVC blood flow going to the IVC, sorry, the RA, IVC to RA, RV blood here. Now RV blood has the choice to go back up to the pulmonary arteries, or actually escape through the VSD and cause a right to left shunt. And with a fixed high pressure on the right side and high resistance, there will be a right to left shunt. And here is what we call the Eisenmenger Syndrome. Eisenmenger Syndrome is a complication of a prolonged exposure to a left to right shunt, plus or minus the high pressure transmitted also from the left to the right. And this stage, the patient will become blue. So a left to right shunt can end up, a patient with left to right shunt who looks pink can end up being blue with variable degrees depending on the resistance and the pulmonary pressure, and then also the development of right to left shunt, or what we call the reversal of shunt, because now it's right to left, it's no more left to right. And this is a very advanced stage where the patient is most likely inoperable because the lungs has been destroyed, the pulmonary vascular bed has been diseased and lost. And such patient may need actually lung or heart-lung transplant to resolve the whole issue, and obviously may need antipulmonary hypertensive medications. I hope I made it easy and clear. Mentioned most of the points. I'm sure you will find upon reading other points that could not have been mentioned here. Thank you for your audience. Assalamu alaikum again. Hello everybody. So our next point or topic in the pathophysiology of left to right shunt is actually the patent ductus arteriosus. What is the patent ductus arteriosus? It's the normal arterial connection between the descending aorta, this is it here, the PDA, the normal arterial connection between the descending aorta to the pulmonary artery. This is normal in our mother's womb because blood going from the right ventricle to the pulmonary artery is not needed in the womb to go to the lungs. Maybe just 10% goes there. The rest of, because of non-inflated lungs with extremely high resistance, the blood will go in utero, right to left, from the PDA to the descending aorta. And we know that the right blood in utero represents actually the blood coming back from the placenta, which is the oxygenated blood, and goes to the body to oxygenate and deliver the needed metabolic need. So after birth, normally a PDA, which has smooth muscles that are sensitive to oxygen, once the baby starts breathing and the oxygen saturation reaches 95, this ductus will actually constrict and close. This is what happens in most of patients, and that's the normal physiology of a PDA. Here we're talking about the PDA as a disease, which means the PDA that remains open after birth by at least 1 week to 3 months, that is a pathological PDA. And as we said in the VSD, because it is a communication between the left side, represented here by the aorta, to the right side, represented here by the pulmonary artery. Again, the left side, aorta, left atrium, left ventricle. The right side, pulmonary arteries. Anything goes to the veins, SVC, IVC, right atrium, right ventricle, right side, of our heart or of our circulation. So the PDA, when it's left as a pathological lesion, will almost always shunt left to right, systemic to pulmonary artery. What applies in the VST talk that we just gave actually applies mostly to the PDA also, with some exceptions. It is a left to right shunt. So a small PDA, usually when we say small, less than 2 millimeter, will actually be extremely restrictive to pressure. So it will not transmit aortic pressure to pulmonary pressure and will not cause any effect on elevating the PA pressure, nor on causing any Eisenmenger or pulmonary hypertension, reversible or irreversible. That doesn't happen because it's going to be extremely restrictive to flow and pressure. And in such small PDAs, less than 2 millimeter, the pulmonary artery pressure will not be elevated. The pulmonary artery tree or arteries will not dilate because they don't see large volume. But again, let me see if you have captured the point I said. The chamber that receives the extra blood in diastole, it is the chamber that will dilate. Let's apply that to the PDA. If blood goes from the descending aorta to the pulmonary artery, now the blood is here. It's going in systole. But is that true? Is it only in systole? No. Actually, it is in systole and diastole. So, because the diastolic pressure and resistance is also higher in the aorta compared to the pulmonary artery. We know the systolic pressure and resistance is higher. Sorry, systolic pressure is higher. Resistance is almost the same. In the aorta, the systolic pressure is higher and it can push the blood to the pulmonary arteries. In diastole, the diastolic pressure also is higher than the PA and it will cause shunt in diastole. So one feature of the PDA that it shunts continuously. That's why we hear a continuous murmur on these patients. There is a big difference between pressures in systole and diastole on both sides. The aorta is always higher in systole and diastole, so the shunt happens in both. So let's go back and say now, this pulmonary artery is receiving the blood in systole and diastole. Would it dilate if that blood was significant enough? Yes, it would. Obviously because of volume and pressure. What will happen? That extra blood will go to the pulmonary arteries and will come to the pulmonary vein as extra blood plus the normal cardiac output that's already coming. Which chamber is going to receive that extra blood from this PDA? The chamber that will receive it in diastole, we said the first was the MPA and the branch pulmonary arteries. The second is again the left atrium and again the left ventricle. So obviously in PDAs, which are not small, moderate or large, moderate will mean 2, maybe up to 3.5 millimeter, and large meaning 4 millimeter and above. In these PDAs, which are significant, not the small restrictive ones, not the ones with less than 2 millimeter diameter, the main pulmonary artery can dilate, the left pulmonary artery can dilate, and the left ventricle can dilate. And I have forgotten to mention in the VST, when we have left ventricular dilatation, the mitral ring may actually dilate, the aortic annulus may dilate, and we may have, because of that, mitral regurgitation or aortic regurgitation, just to complete the picture. Same could happen with the PDA if the shunt was large and significant LV and LA dilatation. So again, it is a left to right shunt and the left side gets dilated. But could the right side also hypertrophy and dilate? Yes, it can. in PDAs, it's actually more common than in the VSD. Not talking again about small PDAs. We're talking about moderate or moderate to large or large PDAs. It is more common than the VSD to have main pulmonary artery dilatation, main pulmonary artery and branch pulmonary artery elevated pressure, and right ventricular dilatation and hypertrophy, because the right ventricle will see the elevated pressure and pressure because of the PDA. This is one feature that's touch different than the VSD. It is more likely with a moderate to large PDA to see right ventricular hypertrophy dilatation and MPA dilatation and elevated pressure, with always the main chamber being dilated, the left ventricle and the left atrium. And do you know why is that so? Why is the PDA different? I said that in the start, that because the PDA shunts both in systole and diastole. That's why a 4 millimeter PDA might equal, which we call large, might equal a large VSD, which is an 8 millimeter VSD, double the size. Because in the VSD, the shunt is mainly systolic, and in the PDA, the shunt is systolic and diastolic, giving more volume, more cardiac output to where it shouldn't go, which is the main pulmonary artery, and stealing the blood away from the aorta. So we will see more LA dilatation, more LV dilatation, more susceptibility to have higher PA pressure and pulmonary artery dilatation, more increased pulmonary blood flow and the effect on the pulmonary vascular bed, be it being more full of blood, and on the X-ray it looks more obvious, apparent, increased, reversed vascular appearance of the lungs on the chest X-ray. Not only that, the effect of a PDA, moderate to large, on the PA pressure on the long run is far much more deleterious compared to the VSD. A large PDA, 4 millimeter or above, actually exposes the pulmonary artery to high pressure during systole and diastole, exposes the pulmonary pressure to extra flow during systole and diastole, and the pulmonary vascular injury is expedited. So in a very large PDA, we don't wait too long. In a very large PDA, from the start, within the first few weeks of life, if we recognize this is the large PDA that's not going to close, it will need to be closed, whether interventionally or surgically, to prevent its complications. The pulmonary arteriolar edema that we spoke about in the VSD will be even more obvious here. The symptomatology will be more obvious. A moderate size PDA will almost be equal to a large size VSD, causing significant dyspnea, whether at rest or with exercise, and significant also failure to thrive, like a large VSD for the patient, because of consumption of the cardiac output to the pulmonary area and the work of breathe that is increased, consuming all these calories, taking it away from the baby and not letting the baby grow. So similar to the VSD but worse is the PDA in causing more left right shunt, more increased pulmonary blood flow, more pulmonary arteriolar edema, more pulmonary hypertension, more LA and LV dilatation, because it is shunting systole and diastole. And also Eisenmenger syndrome can complicate PDAs much earlier compared to a VSD. And it is known that if we come late and cause large PDAs, the pulmonary, even at the time when they show some reversibility, a lot of these patients later on will become pulmonary hypertensive patients because of the previously continued transmission of pressure from the aorta to the PAs has already established some changes and injury in the pulmonary vascular resistance that will continue to develop later on, even after closing the PDA, and develop the pulmonary hypertension. One unique aspect of the PDA pathophysiology, if you have a PDA, there is a good or a different point that we call blood flow steal. What do we mean by steal? You see, in systole, everybody is going to get the ejected blood. That's fine. But it is diastolic blood or diastolic pressure that you depend on to perfuse your body. And that diastolic blood will be stolen in diastole, taken back into the pulmonary arteries, depriving all the organs where this blood is being stolen from the cardiac output needed. So ischemia, especially in neonates and in prematures, can be a pathophysiological feature, and the most common site that we see this ischemia to is to the splanchnic area, the gut, and necrotizing enterocolitis can be an effect of the presence of a very large PDA in a premature or a neonate. Not only that, such steal in diastole may cause the diastolic pressure or the mean diastolic pressure or the mean blood pressure to be much lower than accepted normally, to the extent that it can cause even coronary ischemia, because really the blood in systole is being stolen from every part of the aorta back into the pulmonary artery. And clinically, we can figure out how much is being lost in diastole from that steal by a very wide pulse pressure on the blood pressure, a difference of over 40 to 60 millimeter mercury between systolic pressure and diastolic pressure. I'll give you an example. You might find a baby with a blood pressure of 80 over 30. So 80 is probably acceptable in that neonate, but 30 is quite low. Why is it 30? Because of the significant stolen blood into the pulmonary artery through the PDA during diastole. And these cases really require more attention, because ischemia or lack of cardiac output is of a deleterious effect on the patient. So a PDA is a good example, or follows most of what we have talked about in the VSD, except that it shunts additionally in VSD. It tends to cause more pulmonary hypertension, more left-sided dilatation, can cause right ventricular hypertrophy even from early on because of transmission of pressure to the pulmonary artery, both in systole and diastole. It has a unique part to it, which is diastolic steal. And the last thing, sometimes the pathophysiology of a PDA is associated with a coarctation of the aorta, and that adds to the LV difficulty, because now the LV will be loaded with blood, the left ventricle, and actually when it tries to eject here, it will be obstructed. So loaded and obstructed, receiving cannot push the blood outside. That can give significant heart failure and LV dysfunction. By this, I'm finished with the PDA. I'm sure again there are points that I may have not covered. I wish I have covered most that concerns you. And in our third session, we'll be talking about the ASD. Thank you. Yeah. Okay, hello again. Here we are continuing with our pathophysiology of congenital heart disease. Our talks today about pathophysiology of left to right shunts. We've talked already about the VSD, the PDA, and we're going to talk now about the ASD pathophysiology. So what is an ASD? It's an atrial septal defect. This is the interatrial septum. It has a lower part, an upper part, and we call the secundum, the primum. Regardless, it's just an ASD, atrial septal defect. That means we can have a hole or a defect in the cavity, in the wall, and this is how it would be. So let's follow again in pathophysiology of the heart, follow the blood and make sense of following the blood and know the rules of what blood does to the area it goes to with pressure or without, and then you really know the pathophysiology in a very easy way. So IVC flow, SVC flow, going to right atrium, right ventricle, up to the pulmonary artery, to the lungs, oxygenated, back into the left atrium through the pulmonary veins, the four pulmonary veins, two on the right and two on the left. And we have now the left flow and into the left ventricle. This is normal and gets ejected through the aorta, which I didn't draw just for the sake of explaining the ASD. So as we said, let's follow the blood now. The RV has received its cardiac output. It has ejected it into the pulmonary arteries. It got oxygenated. Now it came back through the pulmonary veins to the left atrium. The blood now has two choices to go through the mitral to the LV, but now we have a hole here. So there is also a chance that the blood can go from the left to the right, left atrium to the right atrium through the atrial septal defect. So how will that happen? Again, blood follows resistance, pressure, easy to go, compliance, and that's how it likes to go. The best compliant area, the least resistant, the least pressure will receive the extra blood. We know that the right atrial pressure is slightly lower than the left atrial pressure. They're not so different, but maybe 2 or 3 millimeter mercury difference. We know that the right ventricle pressure is much lower than the left side, and we know that the right ventricle is much lower than the left side, and we know that the muscle wall of the right ventricle is quite thin and soft, and the PA's or the PA pressure, the pulmonary artery pressure, is also low with a low resistance. So the blood going to the LV, which is more thick muscle, less soft, less compliant ventricle, and now it has the choice to go to a lower pressure, a more compliant ventricle. You think we will have a left-right shunt? Obviously, yes, because of lower pressure and more compliance in the area of the right side, namely the right ventricle, with lower resistance in the pulmonary arteries. And this causes a left to right shunt during what? Systole or diastole? There is not much a big difference in systole and diastole pressure-wise in between the two atria. You see, a normal mean LA pressure will be probably around 6 to 8, with a normal mean RA pressure of around what? 2 to 6. So they meet in that 6 area, and this is the mean pressure, and because of that, the shunt will happen from the higher pressure side to the lower pressure side, and in diastole it almost does not happen because the pressures are almost equal. So this shunt will happen mostly in systole left to right, and because there is no much difference in terms of volume and contraction and pressure on the right-sided atrium, the right side atrium, though it is supposedly receiving the shunt in systole of the atria, but because systole of the atria is not a strong systole, it does not have, the walls do not have significant content of muscle, then the right atrium does dilate because of the left to right shunt in systole from the left atrium to the right atrium. But the right ventricle will also, so I wouldn't say but, the right ventricle will also receive this during diastole from the atria to the ventricle, and here it's very easy to say that the right ventricle will actually dilate, because again, by the rule we said the chamber that dilates is the chamber that receives the volume during diastole. So the first pathophysiological effect is dilated right atrium and dilated right ventricle because of this right to left shunt. Obviously, again, because of the pressure being almost all equal, and because the cardiac output received by the right atrium and the right ventricle is more than usual, than normal, then the pulmonary artery will also receive the additional cardiac output in the same low pressure, low systolic ejection pressure, and the pulmonary artery will also dilate. So a feature in left to right shunt of the ASD is dilatation of the right atrium, dilatation of the right ventricle, and dilatation of the main pulmonary artery and the branch pulmonary arteries. Obviously, we will have increased pulmonary blood flow, increased pulmonary vascular marking on the X-ray, or just normal. ASD, whether small, small for sure, it will not shunt too much, moderate or large, you cannot predict exactly that because it's moderate or because it's large, it's going to shunt a lot. We can say in general, it will shunt a lot, but predict exactly no, because the compliance of the RV will be the governor of how much blood is accepted and how much blood is ejected to the pulmonary arteries. And hence we may find actually, or we do find, most patients with ASD are asymptomatic or so-and-so, quote-unquote, cold asymptomatic. Probably if we stress them enough, if we ask more deeper questions, we may find some symptomatology of ASD patients that are not obvious otherwise. So we got the dilatation effect, the increased pulmonary flow again. So blood now goes increased flow to the lungs and goes back to the left atrium. Now the left atrium, is it seeing too much blood now? Because the pulmonary arteries did see too much blood. Yes and no, it will see too much blood, but again, that too much blood will escape back to the ASD and back to the PA. Actually, some of its own blood will also go there, and hence in large ASDs or moderate to large ASDs, we actually may see the reverse, that the left atrium either is truly smaller or looks smaller because it's compressed by the more dilated right atrium. But again, one feature could be a smaller left side in ASD patients because of less flow going to the left side. This is number 2. So the increased pulmonary blood flow, what is the incidence that they would have truly pulmonary arteriolar edema? That's extremely rare, and I think we don't know exactly why the shunt is not, although it can be large, 3:1, but probably because there is a ventricle between the shunt and the PA, and that ventricle controls what blood go, one, and because this shunt is not a high pressure shunt, does not occur with pressure, like a moderate to large PDA or a moderate to large VSD. So the symptomatology are less, the effect on the patient is much less. What could we see more of pathophysiology? Can we see pulmonary hypertension with ASDs, with fixed pulmonary vascular resistance? That's actually extremely rare pathophysiology to see. You don't see that with ASDs as a rule, but in the very rare occasion, there are ASDs that are called actually malignant ASDs, where PA pressure elevates so quickly early in life, within the first year of life, with the ASD. And as we learn more, that actually some of these patients, it's not just the effect of the ASD, it's actually they do have what we call associated primary pulmonary hypertension with congenital heart disease. So be careful when you evaluate an ASD that has a right to left shunt. It looks like reverse, it looks like Eisenmenger Syndrome, and call it just because of the ASD effect and the shunt effect. Actually, those patients may be the other way around. They are primary pulmonary hypertension patients with an associated ASD that they need to decompress the right side because of the high pressure. One other pathophysiological effect is because of the significant, this is a venous chamber with not much pressure, it tends to dilate much more than a systemic chamber. So we do see quite a bit of severe dilatation of the right atrium and the right ventricle, with the consequence of different atrial tachyarrhythmias or bradyarrhythmias as one of the pathophysiological effects of an ASD on the right side. Very rarely, extremely rarely, that it will cause ventricular arrhythmia because of right ventricular dilatation. It's mostly atrial arrhythmias, atrial flutter in a late presenter, large ASD that has been left for many years is actually a common finding. Tricuspid valve regurgitation because of significant annular, tricuspid annulus dilatation is also seen and can be worse in patients who start to develop pulmonary hypertension with ASDs. Another finding, a pathophysiological effect, that we actually may have a sort of a low cardiac output state on the left side because of a huge left to right shunt. Sometimes even to the extent that the left side structures, as I said, the left atrium may look small, the left ventricle may look small, that even sometimes the aorta, ascending aorta, isthmus and coarctation area may actually become smaller or small enough to cause obstructive lesions into them. An ASD is usually asymptomatic, whether small, large, moderate or large. When we say an ASD that is small, we're talking about 6 millimeter or less. When we say moderate, we're talking about probably 6 to 8, around 6 to 10, and more than 10 millimeter would be considered as a large ASD. ASDs usually close spontaneously when they are small. Moderate to large ASDs tend to stay there for a longer time. So to recap, it is a left to right shunt. It dilates the right side of the heart. It causes increased pulmonary blood flow, rarely causes pulmonary hypertension as a pathophysiological effect. It can cause atrial arrhythmias because of significant atrial dilatation because of the left to right shunt. Symptomatology, most of these ASD patients are actually asymptomatic. ASDs presenting very early with severe pulmonary hypertension, one should always be careful that this could be the other way around. It's primary pulmonary hypertension with congenital heart disease, not Eisenmenger, and the ASD can shunt to right to left. But Eisenmenger syndrome is a complication of left to right shunts, whether it's a VSD or a PDA and an ASD, and that's why the effect of such shunt, if the shunt is important, has to be obliterated. We have to close ASDs that are large enough at a certain age, and we have to close the VSDs and the PDAs that remain to the certain age, weight, and time that's indicated. By this, I finish ASD pathophysiology. Hello to the final session. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Sallallahu sallam wa barak ala nabiyyina Muhammad. Of pathophysiology of left to right shunt. We talked about the common ones, the VSD, the PDA, the ASD, and there are the uncommon ones. Again, with this left to right shunt, quote unquote, we call them the arteriovenous shunts. One big portion of them is systemic arteries to systemic veins shunts. What do you mean by that? There could be a variable variety of such shunts. I'm just going to take away the name and put for you the drawing. If we have the aorta like that, and this is the systemic artery, any connection between this aorta or its components that derive blood from it, these are the coronaries, to a vein or a venous chamber is called a systemic arteriovenous shunt or an arteriovenous shunt. So you can imagine, if we go down from the start, you can have coronary fistulas. A coronary artery may send an abnormal branch towards the apex of the right ventricle, and that would be a coronary fistula. Or the left coronary may actually send a very abnormal branch to the right atrium. We call it, again, a coronary fistula. Arteriovenous shunts, fistula-wise, they act exactly or almost exactly like a PDA, but because most of the time they have restriction of flow just at the end where they enter the chamber or the vein they go to, they do not present exactly like the PDA. They do have a left to right shunt, so the pulmonary blood flow through the venous flow that's being received plus the shunt will increase. The left atrium flow will be increased. The left ventricle flow will be increased. We will have left ventricle, left atrial dilatation if the shunt is significant. We will have increased pulmonary blood flow, and it is extremely rare in these areas because of the length of these arteries, because of the restriction, because of the amount of blood. It is extremely rare that these arteries cause pulmonary hypertension. On the contrary, because these arteries have the similar pathophysiology of a PDA, they do steal from the original vessel they're coming from. So they can steal from the coronary, causing coronary ischemia, which is a pathophysiological effect that we could see in coronary fistulas, and so on. This is one example. The arteries could come from different areas. If this is the brachiocephalic artery, this is the right common carotid, this is the subclavian. We do have here the RIMA, the right internal mammary artery. Such arteries are known to give arteriovenous collaterals, arteriovenous fistulae, and they can go anywhere. You may have an artery from here even to the hepatic. So any branch or any branch from the aorta can give an abnormal fistulous connection, arteriovenous connection from an artery to a vein down to the furthest branch, whether it's the celiac, whether it's the superior mesenteric, whether it's the iliacs, all are a place for an arteriovenous fistula to happen congenitally or iatrogenically if there was an involved injury or surgery or accidents that can lead to those. As I said, they are all left to right shunts. They have the characteristics of left to right shunt, plus the most common characteristic they have is actually stealing from the systemic circulation. Patients will be pink, rare to cause heart failure, but can cause cardiac ischemia or organ ischemia, depend on where that artery is close to. So if it's close to the celiac trunk, you may have even up to hepatic ischemia. Okay, because of the steal pattern. I'm not going to spend more time in there because these are rare conditions, and if we want to explain them, we need sessions specific for them. Our second arteriovenous shunt, which we almost always believe it's supposed to be left to right. Here's the systemic, we covered it already. Pulmonary arteries can have fistulae or arteriovenous shunt. What is the artery in the pulmonary artery? It is either the main pulmonary artery or the branches, nothing else. And it's usually the branches. The main pulmonary artery is extremely rare to give additional vessels other than the branch pulmonary arteries. So if a pulmonary artery is going to become fistula, where is the vein that it should send to? Obviously, the vein that it sends to is the pulmonary vein. So basically, an artery from the branch pulmonary arteries bypasses the arteriolar, alveolar, venular, venous normal channel by an extra outside vessel that connects directly the artery to the vein and hence steals the blood from the pulmonary artery directly to the pulmonary vein. So we call it an artery, but it carries blue blood, deoxygenated blood. So these patients, although they have an artery to vein shunt, but actually it is a right to left shunt. It's from the venous side to the venous pulmonary side to the the pulmonary arterial side, which carries venous blood, to the pulmonary veins, which should carry oxygenated blood, but in this case, it's going to receive the blue blood, and hence these patients may look blue, they don't have murmurs. And which side here will be dilated again? It will be again the left side, which is the left atrium, the left ventricle, because they are the ones receiving the extra flow. So, and this is a very unique condition where the patient is actually blue, but the left side is dilated. It's almost unique to this disease. We are used to patients who are pink with the left side dilated in left to right shunts or arteriovenous shunt, but the pulmonary arteriovenous shunt is different because the pulmonary artery does not carry oxygenated blood. The other different example to left to right shunt, as I said, almost always left to right shunt causes LV dilatation. If I have an aneurysm or an arteriovenous malformation in the brain, like vein of Galen aneurysm, one common example, the shunt is from abnormal arteries in the brain to the venous side directly without going through the usual arteriolar, capillary, venular area. So it's just bypassing, and that's why it's called a fistula or a shunt. And in this case, which side is actually ejecting the blood? It's the artery, which carries pink blood or oxygenated blood. And which is the side that's receiving this extra blood? It's actually the venous side. So in these patients, the receiving area is the big veins. So you will find that they have large internal jugular veins, large dilated superior vena cava veins. And obviously, because all of that venous reception is happening in diastole on the right side, they will have also large right atrium, large right ventricle, and they will be in severe heart failure, sometimes even intractable heart failure. So although it's a left to right shunt, although the patient is quite pink, but it's the right side that suffers because it's in the area of the brain, and the shunt is being received by the superior vena cava eventually. By this, I think I have covered in a decent way, I hope, the pathophysiology of left to right shunt, whether the common and the uncommon. And I do advise you to still read more and follow the two rules. Follow the blood where it goes, and each chamber, what effect it can do in it or on it. And always remember that the chamber that dilates is the chamber that receives eventually the extra cardiac output. And always remember that flow follows the least resistant area, the lower pressure, and the more compliant. Thank you so much.